And thank you, sir. I would be inviting Dr. J.S. Bhalla, Dr. Amit Khosla, and Dr. Manisha Agarwal to kindly join in to unmute and start their video streams. So I take this opportunity to thank the All India Ophthalmology Society for giving us this opportunity to talk to you about artificial intelligence, the current paradigms, and the future directions in ophthalmology. And let me introduce you to the speakers. We have the keynote address is by Dr. Van Lansing, and he is going to be talking to us about surgical simulation in ophthalmology. The future is here. Dr. Van Lansing requires no introductions whatsoever. He has worked throughout Latin America, North America, Southeast Asia, and Pacific in promoting sound surgical training, public health strategies, and sustainable eye care solutions. He has over 35 years of diverse global experience in ophthalmology, and he has worked in disease control in ophthalmology, management of trachoma, diabetic retinopathy, and cataract. He is an internationally applauded faculty as well as a member of the international community for prevention of blindness, having received the American Academy of Ophthalmology International Blindness Prevention Award in 2016, the Pan American Association of Ophthalmology's Benjamin Boyd Award of 2017, the American Academy's International Ophthalmologist Education Award, and the ARVO's Carl Kufer Award in 2019. He is also a member of the American College of Surgeons and the Mexican Academy of Surgery. Welcome, sir. Dr. Van Lansing.
Sir, he is not joined right now.
Already there would be. I don't think we have the stream there. Samriddhi, is there somebody? Do we have a recorded the recorded?
Okay,
stream?
okay, sir. Okay, sir. I played.
Good morning, everyone. I first would like to thank the organizers of this annual meeting for your kind invitation. And I'm wishing everyone in India good health and that your families have not been personally affected. And if you have that, you can recover quickly. You are in our thoughts and prayers. I would like to speak to you today about the role of simulation-based training in ophthalmology, particularly with cataract, and what role does it have? What role does the Help Me See simulator have in this topic? And a little bit of the work that we're doing with our partners in India. What do we understand by simulation in eye care? Well, there's surgical simulation, there's non-surgical simulation, and high fidelity versus low fidelity. Obviously, the concept is not new, just how developed that simulation happens to be, because we have the Kitaro eyes, these models that you can purchase anywhere. You will be able to also peel and do a capsule rhexis in a tomato or a grape, the bionicle eyes. So it just depends what we understand by simulation. It can be as simple as that or an aviation simulation machine. In ophthalmology, obviously, there's a few simulation machines out there. Probably the most well-known one is the BR Magic one, which is based on the on phaco surgery, and also it has the modules for retina surgery, and the Help Me See simulator on your left. The advantage that we have with the Help Me See simulator is that it has haptic feedback and the extraordinary fidelity meaning what it shows you is almost what you would be seeing out of a true microscope. This obviously is, as we said initially, is not new. This comes from what we have learned from aviation, which, as you probably have seen, is so well advanced, level D. And fidelity is what we understand is the high degree of realism that we're seeing. Why simulation-based training? Well, I don't think it takes a rocket scientist to figure it out, because obviously it's not just a simulator, but it's how you train with a simulator. Meaning a simulator can only simulate. The instructor and the curricula around it is what helps you learn and make it safe for the patients in a protected environment. Also, you can repeat several steps. This is the advantage that simulation has over and above your traditional wet lab, because obviously after a while your knife, your blades, etc., your pig eye, your dog eye, or whatever you're using, it has only a limited time, number of times that you can use it. You can learn from your errors, you can repeat all those steps that you're having trouble with, and obviously you're not harming the patient. Well, what does the literature say out there? And there are now a number of papers that have been published, particularly these two most recent ones, which have demonstrated that even with a relatively low level simulation, the results can be a lot better once you're in a real operating theater. Can they be used to improve cataract surgery training? This is a resounding yes, as we will see a little bit later. I would encourage you to, if at all possible, obtain these papers, because they really give you an interesting background, and particularly with our simulator, with the realism that it can offer you. So how do we use our Help Me See simulator? Well, if you're really looking out of a scope or a simulated microscope, the haptic feedback, and needless to say the realistic visuals and the haptic feedback, which you can feel the distinction between holding the conjunctiva, the sclera, penetrating the anterior chamber. So you really are able to feel almost like you were operating on a real eye. It simulates, as you can see, well, I mean, it doesn't look really like a human body, but that's the idea, that you can really feel like you were sitting in front of a patient. The tactile feedback is extraordinary, as I have already mentioned. You can actually see, for instance, realism here, where you can feel that you're injecting viscoelastic and even bubbles in some cases that you can see. It's really amazing. As you're showing, as you're able to see here, you can simulate also the iris damage, change the color of the irises, how deep it is placed in the socket, and soon we'll have a lot of the complications that you can find. Here's just a view of what you can see out of the scope, and you can with doing a capsulorhexis. So when people would say, well, M6 has no value, I can assure you that it does. Particularly in some cases, it should be the procedure of choice. And in this case, in our most recent release, you can do the capsulorhexis with your cystotome or with your trata. And this would be very valuable also for phacosurgeons, or even for those phacosurgeons that are just starting, that you have a runaway capsule where you can actually end up converting to an M6 surgery. So this is an extraordinary tool that can be used by many. So now we have a complete procedure. As I mentioned, we have the anatomical variations. It allows for some technique variations. We know that some people do a bevel up, bevel down, do a left to right, right to left. So this is just a way of allowing the possibility for people to use it in different ways, but always, and I will have to stress this, with a curricula around it. Our partners in India, some of those very big names, and that they've helped us develop the simulator, and that we're doing training and conducting studies with them. Here are some of our instructors in a recent training that we had at LWPI, who are helping us also train some government doctors that haven't had enough experience, and as you can see, they can do it in a safe environment. We also have two at Aravind Eye Care System, and really, one of the things that they really want to see is, particularly for novice surgeons, if the use of the simulator can actually reduce the number of complications that you can have, particularly in your surgeries. The International Society of Manual Small Incision Cataract Surgery, we have conducted a number of training sessions with them and some of the trainees from different institutions. Unfortunately, as you can imagine, we have to put a stop to this in all of this year due to the COVID-19 situation. We do have international collaborators where we have simulation-based training and people doing this. At EMO, where I'm based in Mexico, where we now have even secured continuous medical education points for recertification purposes with the Mexican Board of Ophthalmology. Bascom Palmer at the University of Utah, which is really one of the few centers actively teaching M6 as part of their curricula. The Columbia University, who have now also modified part of their curricula to adopt simulation-based training, and particularly some of the steps of M6. So, needless to say, in these big universities in China, and the cream of a crop of simulation-based education that came in Copenhagen. So, does simulation training work for real life? Yes, it does. We conducted a study that we call a TCC PASTE. It was a randomized control study with residents who had no experience or very little experience in 5 sites in India. It was obviously double-blinded, and it was objectively assessed. And as you can see, the two arms were very, very similar, and the results, I won't dwell too much into them, but you can clearly see that the typical ones that went through your normal training of wet lab had more complications than those that included simulation in their first surgery. And the errors that were still there were obviously far less serious than those that had underwent traditional surgery, quote unquote traditional surgery training. This is a paper that we have worked on. It has been accepted for publication in scientific reports. As you know, this is one of the most highly cited and has a very high impact factor. In fact, the 7th highest impact factor of journals in medicine. And actually, it'll be released on May the 26th. So by the time you hear this presentation, it will be available for you. So what are the key drivers? Shorter training period, increased patient safety. This can help probably train a lot more surgeons, and because as you know, cataract is the leading cause of blindness. So we can probably address prevalence of blindness this way with available technology. So the future is here. I would say that particularly in the situation of COVID-19, and this is a survey that was done in India, but there was something similar that came out of the tri-state area in the US, where the number of surgeries obviously has reduced elective surgery, therefore making it a lot more difficult for residents to be able to obtain enough surgical experience. I wanted to thank all my collaborators because they're really the ones that have done the hard work, the lifting, heavy lifting. And this is our center in Mumbai in India. I welcome you anytime that you want to be there. I'm sure that they would love to have you. Hopefully COVID-19 situation will get better soon. And if you want more information, please scan this QR or feel free to contact us whenever you want. Thank you very much. And once again, God bless all of you and your efforts, and a speedy recovery for all of you, and best wishes. Goodbye now.
Thank you so much, Dr. Lansing. It is actually there used to be this debate about having uh, getting people to train on fully loaded or fully on full aircraft. And I think the year before last we had this training uh, the training of trainers in ophthalmology, and this was a felt need. So it's great to see that we have started addressing these needs, and maybe we need more of it in countries like India.
I couldn't agree more with you. Thank you very much again for the kind invitation. And I think what the advantage that it has over a normal wet lab is that it really allows you to repeat a step that you're having trouble with. And it certainly increases patient safety. And that's, I think, the paramount thing that we can think of. Also, in a normal wet lab, and we're trying to use a blade, there's only so many times you can use it, or you puncture the eye, you cannot use it anymore. So it has several advantages. And this is nothing new. A lot of the papers that have gone out there, they've shown that definitely simulation improves the performance, reduces the learning curve. It's just the advantage that the simulator that we have is now based on an M6 platform, which makes it also more readily available and probably more relevant for a lot of the situations for many of us working in developing countries.
Thank you so much, sir. Actually, I think there is a rescheduling of the time, and I think half an hour or a little more has been shaved off. So I'll rush through the other presentations.
Terrific. Thank you very much, everyone.
Thank you so much, sir. It's so nice to have you here. And now I will call upon Dr. Amit Khosla, who is a leading retinal surgeon in Delhi and is also a great exponent of pediatric uvea. And I will call upon him to talk to us about artificial intelligence and diabetic retinopathy. After that, we will be going back to the first speaker's presentation. Dr. Amit Khosla, do we have you there?
Yeah, can you hear me? Can you see my screen?
Fantastic, sir.
I'd like to thank Dr. Bali for inviting me on this instruction course, AI in diabetic retinopathy. So like all new technology, there is this Gartner's hype cycle where we trigger a lot of expectation, then we get disillusioned and finally get a plateau of productivity. Like the dot-com burst, we had so many software companies, they burst, and then the one which were practical, which had technology, survived. Similarly, in AI, we're going to have this hype about a lot of diagnosis, and then we'll find that we don't have enough doctors to treat what we have diagnosed, and then there will be a practical stoppage. So the aim of any screening program is to diagnose DME and PDR, which are two leading causes of avoidable blindness. But the cost of screening should actually be less than the cost of a doctor's consultation. And there should be large volumes to screen. It cannot be for 10 patients that an endocrinologist puts up a camera, and it's not going to be practical after some time. The limitation is that the technology is missing some lesions, like the raised lesions, the cost of the fundus camera, the manpower to treat the diabetes. The low cost of treatment is not possible. It's very costly with the anti-VEGF. And the AI, who will validate the findings, who will bear the medical legal consequences of the AI technology. So at the moment, the only screening program which is there worldwide, I think, health system is in England. Not even in US that they screen as a national population registry, they screen every diabetic. But we will have to, once we have databases, we will start screening all the diabetics. We need to reallocate the skilled manpower to take the photographs and overcome the barriers of distance and healthcare access. So it helps us predict which patient will have vision-threatening diabetic retinopathy, so we can prevent blindness or handicap. I'm not an expert on AI, but initially we had this machine-based learning where we extracted each feature, every soft exudate, and we copied it. While deep learning will learn on the go and help you diagnose diabetic retinopathy better. So initially you train the set, so up to about 1 lakh photographs are given to a software to analyze and then create this database. But it will have to be region-based because the pigmentation level will be different in all different population, and finally we need to validate it. These are photographs courtesy Dr. Manisha Agarwal, who is using an AI platform in our hospital. You see the both eye, you can see the large cups, you can see occasional microaneurysm here, but you can see the ring of hard exudate, and you see the microaneurysm. So what does it show? It shows that the dot and blot hemorrhages are present in the left eye and the hard exudate, and glaucoma and one. It does not pick up the microaneurysms in the right eye, which are not important. So at the moment, we have 4 technologies which are being used across the world. The IDX system, which is FDA approved in US, it is based on the single camera linked to the internet, and it picks up those patients which needs to be referred to the ophthalmologist. The other is the Red Marker DR, UK-based AI screening program. Third is IART. Fourth is the Google Incorporated, the data was given by Shankar Netrali and Arvind Eye System, and we are waiting for it to be available publicly for us to use. The drawbacks of any technology is that you will need to grade it. The Google system required about 60 ophthalmologists to grade it, and the low quality images will be a problem because majority of the elderly population would have a cataract, that the quality of vision will go down. We will need trained staff to take photographs, the fundus cameras. As the cost of cameras come down, and we can have good chips inside a mobile phone, and we can have links to a mobile phone with a huge quality, because at the moment you have cameras from 2 megapixels to 20 megapixels. The quality is there. So does it classify? Some software classify into mild, moderate, severe with CME. At the moment, if I have a diabetic patient, I will take a color photograph. If doubt, I will do an OCT. I will do a FA or a OCTA to pick up a small NV. So what trial I did in my practice is that all my patients for last 2 years, I'm taking a fundus photograph with a red free. And I found the moment I shifted to a fundus camera, I was able to diagnose much better. I was able to pick up more lesions. So just the availability of a camera helped me become a better ophthalmologist. So we need every ophthalmologist with a fundus camera. Instead, we are providing every endocrinologist with a small camera who can diagnose the disease. So at the moment, all the software are based on fundus photograph. At the moment, we also do not depend solely on a fundus photograph. Sometimes you may have a patient with a vision of 612, and you may have a small CME in the macula, which is picked up on the OCT. So we will have to have software which integrate the DR with the OCT to have a more sensitivity of picking up the diabetic retinopathy. This is the first software, the IDX DR camera, which has an online software which picks diagnosis. So we will require software linked into the machine, so even if it's offline, it should be able to pick up. So they use 900 patients. I will not go into details. It is available on the net for those who want to go into details. Can look up the details on the net. The development of AI will be the ownership and the revenue sharing. Who owns the software? After all, every photograph helps the software to learn better. You are giving data to the software company. So is it your data? Is it the patient's data? Or is it software data? And now that we all know that I can identify a person by the retinal pattern, so can you anonymize the data of every patient? And they will be malpractice liability. Who will be liable for it? The patient privacy. So we'll require consent forms. So, but the main thing is that the more the cameras come in, there's going to be more diagnosis of diabetic retinopathy, more work for the ophthalmologist. So the ophthalmologist gains whether he or she screens, or the machine screens. You want to have more patients. You have almost 6 crore diabetics. I don't think even 1 crore of them or even 60 lakhs are screened annually. Now, softwares are being made with OCT linkage to pick up early. So maybe the optometrist can do the OCT and fundus photograph and then know which one to refer. So these are various publications which you can all go through if you wish to go into more detail. But in short, I'll say the application of AI finally may be linked to your phone, screening at home or in non-medical. Maybe you have fundus cameras in malls, or you may have it at the optometrist shop. Referrals from primary care. So I think the patient wants to not go to multiple centers. So the primary medical or the endocrinologist is going to have the cameras. It will help assist physician to make diagnosis. It frees the physician from repetitive large volume work and alert the physician to the problem, so they can at least make the patient more alert. The screening facilities versus treatment. If you're going to increase the screening, you will have to increase the treatment facilities. And at present, the cost of anti-VEGF is quite high. The fundus camera cost is high. We will require cheaper cameras. At the moment, we are making software, whether for the ophthalmologist, primary care, or for the optometrist to do that. Hazy media is going to be a problem. The pickup rate of elevated the fibrous element, traction detachment, is not there at the moment, so sensitive in these softwares. The medical legal responsibility is going to be there, and anonymizing the data is going to be a problem. So we will end up needing more ophthalmologists. Instead of making the work less, there's always going to be more work with technology. And the software will have to be made offline. Thank you so much.
Thank you so much, Dr. Khosla. Do we have any questions there? Well, I don't seem to be getting any questions. We are actually running short on time. What we'll do is we'll take all the questions right at the end. Right, sir? With your permission? I think we'll take all the questions right at the end. Thank you so much. So basically, we do have some things which are available. We can use them for screening purposes. And in the US, the IDX-DR is going to be reimbursed from this year onwards. And so far as so that was how artificial intelligence is reshaping the management and screening of diabetic retinopathy. What about fields other than diabetic retinopathy? So I will call upon Dr. Manisha Agarwal, who is very active in academics in this field, and they are also collaborators. So I call upon Dr. Manisha to talk about artificial intelligence beyond diabetic retinopathy. Dr. Manisha, please.
Good evening, everyone, and thank you, Dr. Bali, for making me a part of this interesting instruction course. So Dr. Khosla has already made my work easy, so I really don't want to get into the details of AI in ophthalmology. But what is important for us to know is that AI in ophthalmology is important for diseases which require early screening, and that can really make a huge difference in the ultimate outcome of the patient. So diseases like diabetic retinopathy, as already discussed with Dr. Khosla. Then secondly, we have age-related macular degeneration, glaucoma, and ROP. These are all diseases which require a huge amount of screening for the patients. As far as AMD is concerned, we all know it's a disease of the elderly, and it involves the various clinical signs such as the drusen's, choroidal neovascular membrane, RPE changes, and the deep learning basically interprets the fundus images. The sensitivity that has been reported with deep learning is as high as 93% with a specificity of about 88%, which is quite a good sensitivity and specificity. As far as the applications of AI in AMD is concerned, it is basically going to be helping us in knowing which is an active disease and which is an inactive disease. And beyond the fundus photographs, now the AI is also assessing the OCT images of these patients and detecting if the patient is having any intraretinal or subretinal fluid, a choroidal neovascular membrane. Now that's very important because AI can step in the follow-up of these patients and raising an alarm whenever they have to go back and see their retina specialist. So they can actually be technical people who can be just doing the application and just assessing the OCT images and recommending them to go back to their retina specialist for further management. So this is just DL systems are being effectively used again to identify the anatomical OCT features. And these features are extremely important for us to take a decision if the patient needs a retreatment. Again, with the OCT images, the sensitivity reported in literature is as high as 87 to 100%. The AMD diagnosis and accuracy, which has been measured, is as high to the diagnosis by a retina specialist. So that is of extreme importance. These are the various other studies which have been mentioned in literature where they have done the application of AI for screening for AMD. Now, AI also has an application in retinopathy of prematurity, and the two major barriers in ROP screening are the inter-examiner variability in diagnosis, and only a few trained examiners are available for screening ROP, and that is where lies the importance of application of AI. And again, we see that the sensitivity and specificity which has been reported in literature is pretty good for us to do a basic screening of babies for ROP. There is an IROP system that has been also described in literature, which is basically informatics in ROP. And again, if you see the area under the curve is extremely high as 0.98. So they have also created a severity score for ROP monitoring and for treatment, which again has a very high clinical significance. AI to detect, now this is a work which has been done by my group, which is known as the Radical Health Group, where we said that we should not limit the AI only for the detection of disease, but we should pick up clinical signs on fundus photographs. So we picked up 10 major retinal signs. The database included about 68,000 images, out of which about 22 images were of the normal data set and 23,000 had the signs. So this basically, we first trained our algorithm to differentiate between a healthy normal fundus and a diseased fundus. Then we did the heat maps, which basically highlighted and superimposed the images to show where were the areas of the clinical signs. There was a huge gamut of the whole signs, but out of these, we said, let's first focus on these 10 signs. And if you see that the sensitivity and specificity again came out to be extremely high. It was all above 90%, which is extremely good for doing a screening protocol. This Dr. Khosla has already shown, this is the kind of report which gets generated. So you have a normal fundus, you have an abnormal fundus where the AI picks up the subtle changes of microaneurysms and hard exudates. This is again the application of AI in a patient of AMD. It is picking up various signs such as the flame hemorrhages, cotton wool spots, neovascularization, which is there in this patient. So AI basically can help us to detect the clinical signs on the fundus photos. It has again shown an extremely high sensitivity and specificity, and this has a much wider application. AI now is being also applied for cataract, where it is having an accuracy of about 70%, detects what is the grade of the cataract present, and based on that, it can actually recommend whether you are in need of a surgery or not. Something which is interesting, which has come up in AI, is the detection of Alzheimer's disease. So we have the new AI algorithms now measuring the inner and outer retinal layer thickness on OCT images to predict the risk of the Alzheimer's disease. We have a lot of pitfalls in AI application, and that is basically, as mentioned by Dr. Khosla, it can be a high cost of the technology. In-depth training experiences are required for developing these AI algorithms. The basis of diagnosis made by AI algorithms is mechanical, and some amount of human intervention will always be required to detect each and every feature or the variation of a disease. There will always be a medical legal aspect to the application of AI, which we cannot ignore, and there is no 100% solution to the legal aspects. As far as the future of AI in ophthalmology is concerned, it is going to be applied in pediatric ophthalmology to detect leukocoria, and also use of AI in multimodal imaging. So the future is very bright for the application of AI in ophthalmology. So thank you once again for your patient listening.
Thank you, ma'am. Thank you, Dr. Agarwal. Now we will move on to Dr. Bhalla. Dr. Bhalla requires no introduction again. He is a member of the scientific committee and also a very active head of department of ophthalmology in the DDU hospital of the Delhi government. And he will be talking about artificial intelligence in glaucoma. Dr. Bhalla?
Sir, please unmute yourself, sir.
Yes, sir, you're visible, sir.
Yeah. Yeah, good afternoon, everyone. At the outset, I'm thankful to Dr. Jatinder Bali for making me part of this important instruction course. I'm going to talk on artificial intelligence and glaucoma. We all know glaucoma is a irreversible and progressive loss of vision due to damage to retinal ganglion cells. And the glaucoma diagnosis is heavily dependent on the experience and expertise of clinician. Artificial intelligence is the science of applying computer algorithm to replicate intelligent human-like behavior. And this has already been covered, that how ophthalmology is becoming, artificial intelligence is becoming a routine part of ophthalmic practice. And it is basically classified into two algorithms. One is machine learning classifiers, and the second one is artificial neural networks. And what is machine learning? Machine learning is basically the capacity of computer to learn from experience, and algorithms learn on their own by trial and error without being explicitly programmed the steps to do a task. And the neural network is basically modeled on the human brain and nervous system, and where we have network of neurons that are communicating with each other. So this is how it is happening. These are the various images of the retina. Pictures are taken, and then they are analyzed by nodes and internodes. There are connections and cross connections, and ultimately we arrive at a diagnosis, and the output is consistently refined, as was explained by Dr. Manisha. Whereas deep learning is an advanced level of neural network. In machine learning algorithms, we have both the supervised and unsupervised methods. In machine learning, characteristics can help us either to make presence or it can help us decide whether there is presence or absence of glaucoma, and it can also help us to diagnose whether it is mild, moderate, or severe glaucoma. Whereas artificial neural network is dependent on the images, and so it can help us to analyze and make diagnosis of glaucoma from fundus images and OCT images, whereas machine learning characteristic is well suited for handling only low dimensional numeric data like vertical CD ratio, intraocular pressure, age, and sex. In recent years, deep learning has become a go-to artificial intelligence approach, but only problem is it requires very large data sets to train more complex networks. So this is how it happens. We take the, suppose picture of desk is taken, and then what is happened is a portion of this is drawn onto the feature map, and this takes out extracts some mathematical features from the disk, and these are then pooled, and so there is nodes and internodes where there are connections and cross connections, and this multiple repetitions help us to make diagnosis whether there is presence or absence of glaucoma. So what are the goals of artificial intelligence in glaucoma? First, it helps us to make diagnosis of glaucoma, to detect any progression of glaucoma, and also helps us to study risk factors for glaucoma and quality of life. So prediction of how does artificial intelligence helps us in estimation of intraocular pressure? This was first used for evaluation of data from Sensimed trigger fish, and where they use data from 24 prospective studies of triggerfish using random forest modeling technique. So this is how it is done. First, the disk margins are delineated, then the cup margin are delineated, and this helps us to derive various features like vertical CD ratio, horizontal CD ratio, disk damage likelihood scale, and whether isn't rule is violated or not. Optic disc photography is a very important technique where it is being used by a lot of studies have been published, and particularly I would like to quote the study of Teng et al., where he trained on about 5 lakh fundus photographs and he could make diagnosis, and the area under curve was 0.94 with specificity and sensitivity quite high. These are the various platforms where the artificial intelligence is being used for diagnosis of glaucoma from optic disc photographs. These are Pegasus, Netra et al., Netra AI, Indian startup Kalpa Innovations, where we can make the diagnosis from these features. So we can take the picture of the disc. Either the programmer does not know how it is deriving, so it is called black box artificial intelligence, or it is open artificial intelligence, where the disk is localized, segmented, and then heat maps are generated, as was told by Dr. Manisha, and the diagnosis of glaucoma is made. You can also use artificial intelligence for diagnosis of glaucoma for visual fields, which was first done in 1994. And then the another landmark year was 2004, where classification of visual field defect was done. In fact, we can also make pre-perimetric glaucoma diagnosis, where retrospective evaluation of previous visual field of patient is done who are diagnosed with glaucoma based on disc findings and visual field changes. So these are the various studies where visual field have been used for diagnosis. Visual field progression can also be evaluated by artificial intelligence, and they use various platforms like Gaussian mixture model, optimization framework model, and other techniques. OCT, RNFL are also used to make diagnosis, where OCT pictures are taken and RNFL features are analyzed by deep learning. RNFL, besides RNFL, ganglion cell layer thickness is also used to make diagnosis, and these are the various publications where this has been done. So what is done is OCT takes the optic nerve head image, then segmentation is done, and then these deep learning and neural network makes the diagnosis. So this is heat map generation. As you see, these are the POAG eyes in A and B, and healthy eyes are seen here in on-fast and the cross-sectional images. The artificial intelligence has just a minute. Artificial intelligence has also been used for anterior segment OCT to make diagnosis of narrow angle glaucoma, and hybrid techniques where structure and function both are correlated. Visual field and OCT images are correlated to make the diagnosis. It has also been used in genomics to make diagnosis and prediction of onset of glaucoma. So, but there are some limitations, and the limitations are that performance is dependent on quality of data. We use large number of images, and good mix of ophthalmic and non-ophthalmic factors is required, and this training set can be expensive. So the future work is to extract knowledge independent of human intervention, such that new insights and patterns of glaucoma can be derived. So the comprehensive set use of artificial intelligence for glaucoma should evaluate all these parameters: combination of optic disc, visual field, RNFL, ganglion cell layer thickness, intraocular pressure, and gonioscopy. But unfortunately, such a system is still not ready yet. So while earlier methods use machine learning and artificial networks, the newer models of deep learning are making us make the diagnosis in a more active and accurate manner. Thank you, everyone.
Thank you so much, sir. We'll take up the questions right at the end. Thank you, sir. So basically, what it suggests is that the integration is still some distance away, and great effect has already been made. And I'm all right. Good afternoon, everybody. I'm Dr. Jatinder Bali, and I thank the All India Ophthalmology Society for giving me this opportunity to talk to you about artificial intelligence and scientific reporting, the techniques used, the clinical informatics, data management, and everything that is now left behind in this course. Now, I am the chairman of the DOS subcommittee on clinical informatics, information technology, and practice automation. I was formerly heading the information technology wing of a 1,000-bedded hospital in the national capital, and I happen to have written a book on biostatistics and research methods. I have no financial disclosures to make in this presentation. Now, the first thing that comes to mind is that what exactly is artificial intelligence? Very simply put, it is the ability of whenever a machine or a computer is able to accomplish the tasks which required human intelligence, that is artificial intelligence. We're living in the era of driverless cars and Siri and Cortana and Google Assistant, or when you say that whoever bought this also bought bought this. So that is a suggestion that is being given. So that is all. Those are all examples of artificial intelligence. What are the different types of artificial intelligence? Let us focus on these three at the bottom here: artificial narrow intelligence, general intelligence, and super intelligence. Now, narrow intelligence simply means that if you teach the machine to play chess, it improves itself continuously in playing chess. But if it is able to transfer the techniques that it has learned in chess and starts improving, say, in economics or in solving ophthalmology problems, that is artificial general intelligence. That is transfer learning is there. So we are currently in this paradigm right now. But using ImageNet, we have come into artificial general intelligence because we are transferring some knowledge. Artificial super intelligence is at some future time when the machines will be able to pick up information from their surroundings and recursively improve themselves, and there will come a time when human beings are not the most intelligent people on earth, and that point is called singularity. And therefore we want everything to be done ethically, and because there would be these, we were talking about that black box approach. I'll just come to it. So we need to ensure that all the rules that we tell the machine are actually ethically correct. Now, when you look at narrow artificial intelligence, one thing, of course, is robotics, the driverless cars. Then we have machine learning, which could be supervised, where you have, training set. The training set teaches the machine, and then it uses it on a test set and then validates it into other areas. The other is unsupervised learning. Now, in supervised learning, first it is extracting the features, and then it is applying those features for classifying. In unsupervised learning, what it is doing is it is extracting the features as well as applying the classification at the same time. And then, of course, is machine perception, which could be, text to speech or speech to text or image recognition, and what machines can see. Now, why are we talking about artificial intelligence in healthcare today? You see, in the past, it was very expensive to store the data, to store large, humongous amounts of data. Now, memory systems have become cheaper, so we've started storing more and more data, whether it is electronic records or clinical data or electrodiagnosis. Now, every time a patient comes to you, since we have data, we are analyzing it, we're creating algorithms. Those algorithms are further helping people who are not experts in that domain. And that is what artificial intelligence is. When the patient used to come to the doctor, he used to, the interaction used to be a transaction, and we used to write some sort of a prescription. Then subsequently we had these electronic systems where we started keying in those names and numbers, and we would store it either in the form of a prescription or a case sheet, or you could store it on the same computer on which you had fed it, or it would go through wires onto another computer, which could be the cloud, or could be the something called the server, where it would be stored in the form of a master chart or in the form of files. So that is the file transport, FTP servers. Now, this is on this the on this server, limited algorithms which you have already developed are now acting and telling you that whoever bought this also bought that. But suppose you want to develop new algorithms, what do? You cannot do it on live servers. You take this data out and you put it into another computer, which you call the data warehouse. You clean it, integrate it, and then you run data mining tools, or you run different type of tools and find some patterns, and based on that you derive new algorithms. Now, what are those algorithms? Now, in healthcare, the simplest ones that we can talk of are some sort of regression analysis, wherein y is or the disease or the is the dependent variable, and x, z, which could be age, could be gender, could be any of those variables. So these are the independent variables. So what we are trying to do in regression is we are trying to find one equation which explains all disease using the predictor variables or the independent variables. And there are different types of regressions that were described depending on whether it was continuous variable, or it was yes no type of nominal variable, or it was a categorical variable, right? So you could have probit regression or linear regression. The next type of commonly used method is what we call support vector machine. In support vector, what it is doing is it is just trying to find out a line. It is trying to draw a line which is going to separate the cases from the controls, or the yes from the no's, in such a manner that the gap between these two groups is the largest. So this is the negative or positive hyperplane, and this gap remains the largest. So, and then you start using this red line for classifying ROP, no ROP, referable, not referable. Then of course somebody then we talked of finding out about clustering. That's nearest neighbor analysis. So you get a large minus z value that shows there are clusters, that it is all your data or all these points are arranged in clusters, but you get a large z value. The machine says, okay, all this data is dispersed out, and that is how it starts analyzing. And multiple techniques can be used in multiple layers. Then of course is decision trees. In decision trees, what it is doing is it is just creating those it is creating a flowchart, and then on those flowcharts, what it is doing is uh, using those flowcharts, it comes to a decision. When you use multiple decision trees, that's a random forest. For example, you want to see whether it is a hemorrhage. So if it's a red pixel, don't look at a single pixel, look at a number of pixels in that area. And if large majority of the pixels are saying that it is this, then the majority wins. A democratic majority is there. We talked of neural networks, and then neural network, what is happening is all the predictors are acting as an input, and the disease is acting as an output. And in between are multiple layers which are capable of tuning and fine tuning. So I can actually put different mathematical values in these hidden layers to ensure that I get the output. And these are fantastic ones like AlexNet, VGGNet, and GoogleNet, or Caffe and TensorFlow. And then of course the naive Bayes, which acts like our testing mechanisms, where we used to do we used to look at what was the prior probability of disease and then find out the likelihood, and then come to an eventual this thing that this is what is most likely the outcome. So this is when you are trying to teach your machines supervised learning. So you divide the data into two halves, train it using one half, and then test it using the other half. And that is how we're using the classical machine learning methods. Now, so far as reporting in science is concerned, we are already using it for identifying new peer reviewers, fighting plagiarism, sample size, bad reporting, even checking out data fabrication. But neural networks were finding it very difficult to actually report science, because it's a very long string of data, and these work on multiplication of matrices. Now there is a very interesting theory which has come up where they say that look at how the vector rotates, and this rotational unit of memory has been used to run the complete paper into the machine, and number of papers, and they will give you 3 or 4 lines, sum the entire paper, the results of the entire paper in three or four sentences. So this is IBM Watson Health is an algorithm which was named after Thomas Watson, and it has a natural language classifier service which is helping us actually, uh, which is allowing us to using this we can do the reportings. And after this I will come quickly to we've already covered teleophthalmology. We've covered artificial intelligence in ROP. The largest one, of course, is are we out of time?
We
We
have
have 5 minutes.
2 minutes, sir.
Okay, I'll just so basically what we are looking at is we Dr. Manisha has thankfully covered artificial intelligence in ROP, and the only other thing that we need to talk about is teleophthalmology. Now, teleophthalmology, whenever we talk of teleophthalmology and ROP, the first thing that comes to mind is the Sundrop, is the Stanford University network for diagnosis of retinopathy of prematurity, and its Indian variant, the Karnataka Internet Assisted Diagnosis of ROP. Now, what is important to understand in ROP is that all these were feature extraction systems. First, they extract the features, and then classification was done on based on them. We had things like ROP tool, retinal image, multi-slice analysis, vessel map, and CAIAR. And of course, we've already talked of the support vector machine, which says ROP is there or ROP is not there, and refer it. The convolutional neural networks, that is the IROP system, and the IROP's DL based continuous severity score, which helps us actually grade the severity of the severity using a slightly different technique than what is really available. And so far as tele ophthalmology is concerned, telemedicine policy was given by the government of India in March of 2020, and it does allow us extensive outreach, avoids unnecessary referrals, saves cost, and provides professional opinion at a very small cost, and provides protection against infection. However, there are problems. We have connectivity problems. We're trying to sending expensive equipment in these large buses to rural areas, and the data, and trying to do real-time video conferencing, which given our limited bandwidth can be a problem sometimes. In addition, we cannot send systems which require a lot of which are energy guzzling systems. So we need systems which are more like mobile platforms and use lower power settings, and we're trying to push for uh, you know or what we're trying to do is we're trying to push for mobile teleophthalmology units. This is something that one South Indian institution. This is uh, a flow chart that they had made, and this is what they are using. These are just suggestions. There are no guidelines in teleophthalmology that have been issued. And the main problem, of course, is patients are not very happy with it, and there is a very high initial cost of investment, and you need trained staff. Of course, we need to look at the cost of the hardware and the software also. And so far as artificial intelligence is concerned, we've already covered the fact that there are medical legal issues and regulatory issues. You see, the doctor-patient relationship, the patient comes to the doctor, and this is acting only as a decision support tool. Minus IDXDR, there is no other direct relationship that is there with the patient. And whenever any suits are pressed, they will be pressed against the practitioner. So we have to ensure that we don't get caught up in a tussle where we are not able to explain why a particular decision is being taken. At some stage it is going to become like that, where we won't be able to explain how we got to a particular decision in terms of say the diagnostic abilities of these machines. And that is the reason why we need to look at the privacy concerns, the data anonymization issues, and also the fact that you see these algorithms are being developed on data which is not being generated in the place where it is going to be utilized. So you will need some sort of bridging studies, and all those are issues uh, which need to be evaluated and accepted. So I thank. With that, I come to the end of my presentation, and I thank. I thank the participants, and now we are open for any questions. We still have 2 minutes. I think we have 2 minutes, isn't it, Samriddhi?
Yeah. So
Okay.
I have a question for Dr. Manisha. Is Dr. Manisha online?
Ma'am, are you there?
Can you unmute yourself?
Yes, I'm there, sir.
So Dr. Manisha, I want to ask, this software, does it change?
This software, we lost you, sir. This software,
Can we have serial photographs change in the, or it is an individual one-time photograph analysis of the AI for diabetic retinopathy?
As of now, sir, it's a one-time analysis. The AI is not really doing an analysis of the serial photographs. So basically, it has been trained to recognize these signs. So it's just a one-time. If we are looking at that, we feed the sequential photographs of the same patient and they recognize the change. I don't think they're currently doing that.
sir,
Is
actually,
this photograph pardon.
sir, actually,
Yeah.
the what they have used is the algorithm that is used is basically to differentiate. It extracts the features, and it wants to draw a line between the normals and the abnormals. So once it is abnormal, what you're looking at is sequential analysis that has been done in glaucoma, but so far as image analysis is concerned, not been done as yet.
Second is that is this cameras linked to your HIS system? Can you store that data? Or it is independent of your HIS.
Independent, sir.
So you can't keep the data with you.
No, sir.
Ma'am, isn't it HIPAA compliant? Because if it would be HIPAA compliant, it would go into your HIS.
So actually, we have on purpose not tried to do that, because right now we don't want anybody or whosoever to access the images. So we wanted to keep the system totally as a separate system.
Okay.
I'm sorry, doctor. We will have to
And-
conclude
Not
this
so
call now.
strict as of now.
And ma'am, how do you anonymize the data?
Yes.
Chaliye. Thank you so much. I thank Dr. Bhalla, Dr.
I
Manisha.
just wish Dr. Bali that the organizing committee had informed us regarding the time of the talks. 10 minutes possibly cannot be reduced into a 6 minutes talk. And unfortunately, we all appeared that we were overshooting the time with all those bells and rings going on.
Yeah.
I agree.
Sorry
It was
about
bad.
that.
It was actually bad.
I agree
No,
with
I
Manisha. yeah.
apologize, and I'm really sorry, but this was a very last minute note that we all received because the
Actually,
schedule
even
was
I came to know about it just
8:55.
now.
Yeah.
At the beginning of the thing, she just sends me a message to all panelists, and that's it. So we
Yes,
could not even,
right.
I wanted to highlight some things that Dr. Khosla is doing,
Absolutely.
and Dr. Lansing is here. It would have been wonderful to have a tete-a-tete with him. It's not very often that we get international luminaries like him.
I agree.
Thank you,
And
everyone.
thank you for those kind
Thank you,
words.
everyone. Thank you.
Thank you.
Thank you. Thank you,
Thank you so
doctor.
much, sir.
Thank you,
Thank you,
Thank you,
Dr.
everyone.
Lansing, Dr. Bhalla, Dr. Manisha, and Dr. Amit. And thank